You're listening to Astonishing Healthcare, the podcast hosted by Capital RX, focusing on the biggest issues affecting healthcare consumers, benefits plan sponsors, and health plans. We're covering the inside baseball on how things truly work, or don't, in the U.S. healthcare system and pharmaceutical supply chain in an astonishingly efficient way.
Hello, and thank you for joining us for another episode of the Astonishing Healthcare Podcast. This is Justin Vinieri, your host and Senior Director of Communications at Capital RX, and Bridget Mulvenna, Vice President of National Business Development, is back in the studio with me today to chat about how things are changing, with a focus on biosimilars and specialty pharmacy. We're going to be discussing what she's been seeing and hearing out there over the 2025 selling season, how she's working with plan sponsors to address some of the issues around biosimilars and specialty pharmacy. Bridget, thanks for joining me in the studio again.
Great to be here. Thanks for having me back.
So starting off, rebates, they've been a core financial lever, and I don't think we can have this discussion without a little bit of setup. Can you talk about the role of biosims and specialty there and sort of fueling rebates for plan sponsors?
Well, yeah, specialty drugs at their core are biologically derived drugs, whereas non-specialty is chemically derived. And so I think that's a great way to sort of delineate those two. Specialty drugs have dominated the market and have really taken over plan sponsor spend, pushing 50 and in some cases higher 50+% of total spend, while only being about 2% of use. And so that should definitely indicate to people that they're very expensive. And so as biosimilar drugs, which are not generic equivalents of specialty drugs, enter the market, we're going to see significant reduction in total rebate value because the price of the biosimilars are significantly lower than the prices of the original specialty product.
So you've talked about ending our addiction to rebates previously on the show or webinars. When do you think we'll see meaningful change there? It's like a price of the drug, and then there's a rebate. So there's this gross to net bubble, and then there's drug mix, and you can see how things change or don't based on how you're managing the plan. Do you think we're at an inflection point? Do you think plan sponsors really are starting to understand the math better?
I think some plan sponsors do. If you understand that if your rebate offer for a PBM contract is high, that means your drug prices or your total net cost is going to increase as a factor of that, then you're able to make better decisions. But there are still plan sponsors who are addicted to that high rebate number. And if you're doing an appropriate biosimilar shift, the rebates should be significantly lower than anything that you would see in an arrangement where you're favoring those legacy or originator products. And I'll throw some examples out there. Right now, the hot topics are around Humira, which has had biosimilars available in the market for a while. And there are some interesting idiosyncrasies around that specific drug. And then Stelara, which really started to see biosimilars enter the market this year. And that if your rebate guarantees are still sitting at around $5,000 per specialty product, then that should indicate to you that there's probably not a favorable biosimilar offering in place at your PBM, because rebates should be much lower than that on a specialty guarantee if you're favoring biosimilars. And one example I'll use is like Stelara. If you just look at the WAC of Stelara, it's upwards of $26,000, $27,000. But the average price of the low WAC Stelara biosimilars is somewhere around $4,000. That's a giant delta just in cost. And so at that point, I'm thinking, who cares if you get a rebate if I'm paying $4,000 today for a drug I was paying $26,000 for yesterday?
And what should self-funded plan sponsors do now? Can they reframe the value equation and sort of refocus what the intent of their program is? Can they pivot to more of a net cost approach easily? How does that work?
Yeah, I don't know how easy it is for folks to pivot to a net cost equation, because in order to do that, you need data. So rewind to our episode in May. You need to be able to have your data to understand what's happening. And if you do have your data, then you're able to evaluate what was the total plan paid cost before and after rebates. That's how you get to net cost, right? And there's a new thing in the equation, not really new, but it's sort of taking over the industry because of the rise of some other high-cost brands. So there's copay assistance dollars too. And so how do you really get to your true net cost if you don't know exactly what was dispensed, what the rebates were, and what copay assistance dollars were that were passed on then to the plan? So the other thing is that how do you know that your members are accessing the lowest net cost option? Because as I stated before, there have been Humira biosimilars in the market. There are a couple of products that several vertically integrated PBMs have private labeled, and those are generally at a higher WAC. And then there are a handful of low WAC biosimilar options, which, again, define biosimilars. These are drugs that are biologically similar to the originator product. They're not generic equivalents, but some of the newer biosimilars that have entered the market are what we call interchangeable in the same way that, say, a generic and an originator brand product are at the pharmacy. So really important to understand, which ones are on the formulary and whether or not the originator product is favored because of its rebate status or low WAC biosimilar options are favored because of their status.
And neither of us are clinicians, so we're not going to go too far into the rabbit hole here, but it's interesting, Humira, Remicade, Enbrel, there are several. You mentioned Stelara. How should plan sponsors and how should they explain to members the decisions they're making regarding the formulary and the sort of cost management approach to try to balance the access and affordability?
Well, I think you have to sell it two ways. If we're going to keep costs down and continue to provide robust benefits to all of our employees and their family members, then we need to make these decisions to adopt a biosimilar approach, maybe give up some of the rebates, but end up with a lower net cost at the end of the day. There's also a need to educate prescribers. And so working with your PBM or your PBM account management team, and again, it varies across the industry what that looks like, come up with some verbiage around that you can use to educate your members on why you made this decision, that these are the same as generic drugs in essence,
Unquote. Yeah, air quotes. I saw the air quotes there.
Air quotes, in essence, they're biologically similar, and they are also going to help reduce overall plan costs, which potentially can have the impact of maybe we won't need to raise premiums as much next year. And that's happening a lot across the industry right now because healthcare costs in general are going up. Pharmacy still remains a large part of that, but pharmacy costs are generally not the primary focus when we're talking about a renewal every year. We're really focused on what the overall medical is going to cost from a premium perspective. And so maybe we can keep premiums low. Maybe if we shift enough of these specialty originator products to biosimilars, we can reduce the copay on those drugs and maybe put them in more of a brand category because there comes a point where the pricing of these biosimilar products starts to approach more of what a high-cost brand is versus a high-cost specialty.
Interesting. In a way, my next question was sort of about reassessing PBM contracts. And You've talked about the contracts before. Josh has talked about contracts before. On our Pharmacy Benefits 101 rebates content, Ben talks about contracts and the importance of the contract definitions. What can plan sponsors do? Is it the buckets you were just talking to and like how they think about providing the access to the medication to the plan member through the plan design? And then having the contract just reflect like, hey, this is how I want to categorize these drugs, or do they not even worry about it and you want to make sure that the definitions are broader and inclusive?
Well, I think you hit it a little bit. Build your plan design in a way that favors biosimilar use. In some ways, try to incentivize people to use more biosimilars if you can. And trust me, financial incentives work best. That was been my experience when I managed a plan. It's been my experience here in driving more generic and more biosimilar utilization. Financials make patient decisions easier, especially when patients are suffering to buy basic things like gas and food. right? And prescription drugs are a big part of the rising costs of everything in America. So that's around plan design, right? But let's talk about contracts. You need to understand your PBM's policy. Are you going to be penalized if you move to biosimilars? If there are penalties to not go with a high-cost branded product or for not adhering to a formulary because there aren't enough low-WAC biosimilars on formulary, that's a red flag. And so that sort of disincentivizes biosimilar use, which in my mind, it really is kind of a gross use of power that the PBMs have, that they're driving folks to use more expensive products. And then push for transparent pass-through pricing. You want to reward lower list prices and not bigger rebates. And I think that that's really critical, is that when you're evaluating a PBM during an RFP and you're looking at that bottom line number, often what's winning, not all the time, but often what's winning is the highest rebate. And I can't say this enough. The bid with the highest rebates has the highest all-in drug costs. And it's not a guess, and I'm not making this up, and I'm not pretending to know this. This is a fact.
And as a plan sponsor in the seat you used to sit in, how did you think about, you had your data, you were good at crunching the numbers on your data and understanding what was driving costs and what your members needed. How do you think about clinical engagement and the clinical programs around these higher cost drugs and chronic medications, for example?
I think it's really important to have a high degree of clinical engagement and to have a PBM partner, your internal partners. You've got that fiduciary committee. Everyone needs to be educated. And then you need to have a coordinated communication plan, maybe lettering campaigns out to physicians. So if you have your data, then you have all of the NPIs or the national prescriber codes for every physician that has prescribed these drugs. And so you can extract that data down and develop a communication plan with your PBM to outreach to those providers. This plan is favoring biosimilars, and send some education to the providers, but then also provide in your open enrollment materials, one-pagers, in your open enrollment webinars and informational sessions that your PBM sometimes attends, information about biosimilars, because people do get nervous when their drug changes. And we've found that as we've had major shifts away from originator brand products in the chemically derived position, there has been some pushback on generic drug use. And it took years to get a more broad adoption of generic drug utilization. And a lot of that happened around plan design and zero copay options. We need to do something similar around biosimilars and kind of focus on plan design and ways that we can not only educate, but also incentivize members to use biosimilar products. Maybe they're having two specialty tiers, almost like there are generic specialty drugs and there are brand specialty drugs. Let's move those biosimilars into a generic tier and let's start driving people towards those lower cost products.
Interesting idea. Okay. And then I guess let's talk a little bit about what's next. I'm going to start with one of the hotter topics, of course, GLP-1s, cell and gene therapies. These categories are huge. Sometimes they are, sometimes they aren't in the pharmacy benefit on the cell and gene therapy side, of course, but GLP-1s are very squarely in the pharmacy spend. Can you talk a little bit about how plan sponsors, you've talked a lot about how they can manage GLP-1s or try to in the new world we're in. Previously, what are you seeing right now? What do some of the strategies look like that have potential to work? Talk to us a little bit about these super inflationary drug classes.
Well, I'm going to give you my crystal ball prediction, which is today there are, as many GLP-1s as there are in the market. More are coming. And I don't see the price changing much. And so we're sort of going to be living in this land for the foreseeable future where the prices of these drugs are going to remain relatively stable as to where they are now. And some people might not think stable. Some people might think stagnant, but we'll call it stable. There are decent rebates there. Make the best use of weight management programs. The FDA guidelines basically state that it's favorable to have someone who is on a GLP for weight loss also be engaged in a lifestyle management program. And the same for someone who is taking a GLP-1 for diabetes, right? It's very smart to have some sort of weight management program. I'm seeing large health systems have their own programs that are both mandatory and optional. Consider making these more optional so that there's no rebate impact because you want to maximize the total value of your rebate. And you want to continue to evaluate whether or not covering GLP-1s for weight loss is providing the most benefit to your employees and to the plan. And make sure you're with the PBM that is going to employ the FDA guidelines rigorously, because you don't want, and I will stand by this forever, people can go out into the marketplace. There are still compounded GLP-1s available. Let people who want to use it cosmetically or for off-label indications use it that way, because that has no cost to the plan. But if you're covering it as a plan, make sure that your PBM is following FDA guidelines and not approving GLP-1s for diabetes for people that don't have a diagnosis and don't have an appropriate A1C, and then not approving GLP-1s for weight loss unless the BMI meets the FDA guidelines. And those change sometimes. And so pay attention to what that is.
What about precision formulary design? Like, that's part of what we talk about with unified medical pharmacy claims, the potential to get to precision benefits, essentially, and precision payments for outcomes, so value-based contracts. I know I'm kind of bundling a couple of things together there, but you share your thoughts on how you see that evolving?
Well, I think that what we're doing at Capital RX, and again, I know we don't like to get too salesy here, but that is my job. What we're doing here at Capital RX by launching Judy Health, which is basically unified claims processing, is the first step of a long journey to get the entire industry there. And it's monumental paradigm shifting change. We'll see what adoption looks like over the next couple of years. I know we do have a couple of clients that are going to go live, and we've already been servicing our own population there. I think that that is going to assist plan sponsors in identifying common medications that are treating conditions. It's also going to help us see in real time how office visits lead to medication changes and whether or not physicians are initiating certain types of therapies, be they generic drugs or biosimilar drugs, at the point of prescribing versus writing for those originator products because it's the name they can remember, and then letting that change once the PBM gets a hold of it because of some formulary-driven strategy. And so I think that you can almost set up a formulary so that it automatically favors biosimilars. But we want to make sure that when we're making precision formulary decisions, we're not doing it in such a way that doesn't provide patients and physicians with adequate choice at the point of prescribing. Because again, another way to get to precision, and I know that you've had conversation on a prior podcast about this, is pharmacogenomics, which has been around for a while but has not really caught fire. I think if you combine the PGX pharmacogenomics with unified claims processing, you have an incredibly powerful combination to care for and treat patients at an N value of 1. And that, to me, is what healthcare should be about. Healthcare is not about what works for every person like Justin, who is Justin's age, who is genetically male. Healthcare is about what is going to specifically work for Justin. And that, to me, is where we are going. It's where we've needed to be for a long time. You mentioned value-based contracts, and so I'll kind of tie that up a little bit. Value-based contracts are a very interesting trick and tool that pharma is using to tie outcomes to additional rebate revenue. And it is often not money that's being passed through to the PBM because it's paid so far in arrears. But also, I question the ability for pharma to determine outcomes without unified claims processing and the data that that would provide. And so it's interesting to me how that's going to work over time. And I think it's something that we all need to watch and be aware of.
All right, here we are. Last question. Bridget, thanks so much, as always, for sharing your thoughts with us. What would the most astonishing thing you've seen be related to our discussion today, biosimilars, rebates, et cetera? That's safe to share, of course. Always have compliance hats on. Tell us a good story to send us off.
Well, I'm still shocked and astonished when folks make a decision during the RFP process after all of the fiduciary lawsuits and all of the language in those contracts around the opacity in pricing and the opacity in rebate reporting and things like that. I'm still surprised when folks pick the offer that has the highest rebate, especially if they have done any procurements in the past. And in my experience, renegotiating those contracts with those big rebate offers was never favorable, and none of the savings that was promised was ever realized because those contracts favored higher cost brands. And so hopefully that starts to change in a future session when we talk. I'll say I'm astonished by the fact that people are actually finally starting to make the right decision.
Sounds good. Well, Bridget, thanks so much for taking the time today. I hope you have a great rest of your day.
Of course, you too, Justin. Thank you.
Thank you for listening to Astonishing Healthcare by Capital RX. Head over to cap-rx.com/insights and visit the podcast section for show notes and other relevant content. If you liked this episode, be sure to subscribe so you don't miss the next one. And definitely share the link to the show with your network if you enjoyed it. Have a great rest of your day.